Thank you so much. And it really is, an honour to be here speaking, and I'm so pleased that everyone's made the effort to come to Liverpool, and also those online for taking the time. I really hope you find today valuable and useful. I'm going to give an introduction to CLL this morning. For some of you, that might be things that you already know, but I hope it can generate at least ideas, discussion points, things that you can take through over the course of the day, take things home with you as well. So being given a diagnosis of CLL, as a clinician, I actually find that first patient encounter, given a diagnosis, really, really challenging. Amongst all the things that we do, it's a really difficult discussion to have. And I think firstly for us, we're at a Clatterbridge Cancer Centre, so patients are already coming in the knowledge that they're attending that building. They may well have, patients may well have relatives, friends with cancer experiences. So it's a very emotive experience. And when they're coming into the clinic, they're being given a cancer diagnosis, but also then being told, but it's okay, and we might not actually need to do anything. And so that's a really difficult kind of mixed message in a sense, because I guess historically you'd think cancer, this needs action, but learning to accept that it doesn't necessarily need something doing, and living with uncertainty is really difficult and hard to get across in that one first patient review. So there's certain things that I, as a clinician, think are important that we discuss in that meeting, but I'd be really interested to hear more from yourselves about how you felt your initial review went, and things that you wish you had been told at that review, things that actually you'd prefer not to have known at that point, so that we can learn from your experiences as well. And that's one of our discussion points, I think, today. So the definition, so chronic lymphocytic leukemia, you may well have seen this picture before. It's on quite a lot of the literature, but this is essentially how blood cells are made, so made originally from stem cells that are in your bone marrow, in your long bones and pelvis. And so these cells divide and differentiate, and it's from B lymphocytes that CLL originates. During their division, there is an abnormality, so something changes, and leads to the development of CLL. And these cells build up in lymph nodes, bone marrow, and peripheral blood. And as a result of that build-up, various symptoms can develop. So if in the bone marrow, CLL takes over the bone marrow, it can reduce the production of other blood cells. So patients can become anemic. They can have low platelet count, which can lead to bleeding or bruising symptoms. Or low other white blood cell counts, which can make them more prone to infections, and we'll talk more about infections in more detail. Lymphocytes building up in the lymph nodes can lead to kind of the enlarged lymph nodes, and I'll show a picture of that shortly. And the effect on the immune system we'll cover it in more detail as well. So I thought this picture is just helpful because when you are seen in the clinic, we will often examine you. And the places that we examine can seem a bit unusual, but it's basically just the places where we can feel your lymph nodes. So we often feel the neck, the underarm, and the groin, and also try and feel for your spleen. But there are lymph nodes elsewhere in the body, hence why sometimes if you're approaching the need for treatment, we will sometimes do a CT scan, that will detect the lymph nodes elsewhere and show us their size. So a little bit about the statistics. So chronic lymphocytic leukemia is the most common leukemia in adults, with around 3,800 new diagnoses in the UK each year, with a median age at presentation of 72 years. It is more common in males and is not usually curable. So living with early stage CLL, we saw before that there's a number of patients here being actively monitored. Up to a fifth of patients will never need treatment for their CLL. And going back to that first review, at that point, it's really hard to kind of get that message across, but also at that point, we don't really know who those patients are. So sometimes we will do prognostic markers, which will give us an indication as to how the disease might behave, but actually the kind of best measure of knowing that for patients is time and seeing how patients' blood results change over time. And so there is that period of not knowing how things are going to go. There is kind of some disease factors when we're looking at your blood results. So if your blood count is well preserved, if your lymphocyte count is not very high, and if you do not have significantly enlarged lymph nodes, and we talk about this lymphocyte doubling time, so how quickly the white blood cell count goes up, and if that's over 12 months as well, then there's an 80% chance of being alive at 10 years, and 15% of these patients will require treatment. And I think during this time, actually, there's very little you can do to impact the disease course. And the main important things that we would press upon patients is maintaining a healthy lifestyle. So diet and exercise are important, but also your mental well-being. So I think things like this event are really important in helping you realise that you're not alone. That there are lots of other patients out there, and how they manage the uncertainty of their disease is really helpful. By doing these things and maintaining a healthy lifestyle, if you do then require treatment in the future, you'll be in the best health possible for that. So I briefly touched upon the vulnerability of patients with CLL. So patients are vulnerable to infections, and that's both through just having the disease itself, but also through its treatment. And there's, at a cellular level, there is a number of reasons why that is. So reduced immunoglobulin levels, which can often be through the treatment that patients have had. Impaired T and NK cell function, these are other types of lymphocyte. Neutrophil function and neutropenia are impaired both through the disease and its treatment. So immunisations, so helpfully in your pack today there is a vaccine record which you can take away with you if you do not already have one. So we do suggest that patients maintain a vaccine record, because I don't think everyone is aware of what the recommendations are. You should seek an annual flu vaccine. COVID vaccines I'll cover on another slide. The pneumococcal vaccine is recommended at diagnosis and is generally 2 doses that you require. If you have suffering with recurrent infections, it can be helpful to check your antibody response and consider whether or not further treatments are needed, but generally it's then 5 yearly that is required. You should not be having any live vaccines, and one of the vaccines that up to relatively recently was off limits was a shingles vaccine, but now we have the widely available Shingrix, which is non-live. At this time point, its guidance is for those 70 to 79 years, but we'll often can ask primary care to administer it to our immunocompromised patients, but actually the recommendation is hopefully changing soon to be those over 55 and immunocompromised. So COVID vaccines, so hopefully you've had lots. So I think we're up to number 7. Excuse me. And following this kind of schedule. There are lots of studies looking at how effective these vaccines are in CLL patients. We now have a reasonable amount of data showing us that there may well be a plateau in the amount of patients that achieve this seroconversion, achieve this response to the vaccine after 3 doses, and that runs at about 80%. So there's still a number of patients, a fifth of patients that may not have that immunity. What is reassuring on the flip side of that is that those that do respond, once they've had all of these vaccines, tend to have similar antibody titers to healthy controls. There are specific factors that may make you less likely to respond, specifically low immunoglobulin levels, if you're on a BTK inhibitor, or you are imminently due treatment. Just mention of a study that we don't have in Liverpool, but is running elsewhere. It's running in Birmingham and I think Stoke and other southern centres. So the IMPROVE study is looking at whether interrupting BTK inhibitor therapy for the vaccination improves response. And so that's currently recruiting, excuse me, and so hopefully we'll have results later in the year from that. COVID treatment, so CLL patients are eligible for treatment of their COVID, excuse me, needs to be within 5 days of symptom onset. And it's arranged out with our centre, so we were a little bit kind of set back from how this is run, but having had patients go through this, if you register your positive test on the government website, you'll generally get called. And if you don't, you can phone 111 and it's arranged through a treatment centre where you'll either get an antibody, monoclonal antibody therapy or antivirals. Supportive care. So separated this out a little. So some patients not on treatment, but also those that have had treatment or during. Antibiotic prophylaxis is generally our kind of first port of call in patients that are suffering with frequent chest infections, and we have different ones that we can trial. If despite a 6-month course of those antibiotics with no relief from those recurrent infections and low immunoglobulin levels, we can apply and try and obtain immunoglobulin replacement, which is monthly. Pain relief is just something to mention. If you have progressive CLL with pain from spleen or lymph nodes, then it's an important aspect to just bear in mind. During treatment, you will have additional medications, specifically Septrins, an antibiotic that we often give with a lot of our targeted therapies. Antivirals might be needed if you've had a history of viral infections. And if you have low blood counts, then you might need either injections to boost white blood cells or transfusions if you become anemic. When to treat. So these are the kind of criteria that we're working off when we are reviewing you in the clinic, to consider whether treatment is warranted. And so patients generally with stage A CLL do not require treatment and are monitored. Those with stage B disease with worsening blood count, lowering blood counts, or a rapidly rising lymphocyte count, very bulky lymphadenopathy, and bulk here is over 10 centimetres, so that's really big lymph nodes that are progressive and causing symptoms. Splenomegaly in the same aspect, and then symptoms such as kind of dramatic weight loss, drenching sweats, or significant recurrent infections. There are some autoimmune complications that can happen with CLL, so sometimes you can develop a problem where you're destroying your own red blood cells, or indeed platelets, which can cause dramatic lowering of one of those blood counts. And the treatment for those tends to be steroids, but if not responding to steroids, then we have to think about treating the underlying CLL if it's a significant disease burden. Or stage C disease, which is a significantly low blood count or platelet count. So active monitoring, or I think it was always watch and wait, or watch and worry, I think is the tagline. So when we're seeing patients that are being actively monitored, you will be asked questions to look for symptoms that may be related to progressive disease. You'll have blood tests. You may or may not have a physical examination, feeling for your lymph nodes and spleen. And depending on the level of disease that we're seeing in your blood count, you may have prognostic tests at that time, and that will just give us an indication as to how the disease might behave. And we can talk about those in more detail, but it gets a bit technical. I think it's useful for us, and it gives us an indication as to how often we should be monitoring you. And those appointments may be face-to-face appointments, but a lot of people that are stable will be on either nurse-led telephone appointments, or sometimes we have portals or online trackers that you might be on. And hopefully you all have contact numbers for your clinical team, as it's really important that if you do have concerns or worries that you raise them and they can be addressed in the clinic. The reason that we do active monitoring and we don't rush in with treatment, there are a few. So one being a very historical trial that showed that observation was better than treatment with oral chlorambucil at an early stage. The treatments, albeit much improved over recent years, still have associated side effects. And as I said earlier on, there's a number of patients that will never require treatment, so you're really exposing people to unnecessary toxicity. And so going on to treatment, so when people do need treatment, we have excellent first-line options. And, the treatment of CLL has really transformed in recent years. Those of you on treatment may well be on some of these. So now for frontline treatment, we have acalabrutinib, venetoclax obinutuzumab, and also ibrutinib venetoclax. And I think zanubrutinib is now being looked at as a possible additional option. So we're almost in actually the problem now is which of these excellent treatments is the right one for our patient. And this becomes much more of a discussion rather than knowing that one is particularly better than the other. You have options of fixed duration treatment versus continuous therapy. The side effect profile can be important, so if you have other medical conditions, then that might lean us towards a certain treatment over another. And disease factors, so some patients with high-risk disease, we might be inclined to consider continuous therapy over the fixed duration, but that would also depend on patient preference. In general, most centres do not believe there's a role for chemotherapy anymore, although there is a small cohort of patients that we still believe can potentially have kind of long-term remission or cure from FCR. And our aims with these treatments is to achieve a remission with a long duration, so a number of years. A brief mention of transformed disease. So up to 10% of patients can experience a transformation and a change in the way that the disease is behaving. And that's either to a more aggressive leukemia, a high-grade lymphoma, or a high-grade lymphoma. And the symptoms to be mindful of when we're worried about this is a sudden change in lymph nodes, dramatic systemic symptoms, so the weight loss, night sweats, feeling generally unwell, can mean that you should be seen and assessed. And in these scenarios, you require additional investigations and a completely separate management that does usually involve chemotherapy. And then just a mention of support. So obviously we have CLL support who have put on today and are an excellent resource. You will hopefully have your local team and their contact. Macmillan have excellent kind of online information, literature, and also additional support for patients, the UK CLL Forum and Leukemia Care. And so these are kind of places that I would direct you for more reading, more patient experience, rather than any other websites, really. And that's the end of my introduction. If there are any questions.
I was diagnosed 12 months ago with CLL by Dr. Ranjit Dasgupta, who you may know from our part. Stage A CLL, and I'm on watch and wait at the moment with my GP. But also on the diagnosis, he wrote something that I didn't quite understand. It said stage A CLL, IgG, Mugus, CLL related. Is that something additional, or is that just part and parcel of having CLL?
It's additional, in a sense. So this MGUS is this. It's got a long term. So it's monoclonal gammopathy of uncertain significance, and so it means that there's a kind of small protein floating around in the bloodstream, and that can be associated with other blood conditions. So patients can be referred to our clinics just with that small protein, and in that scenario, we're looking for other blood cancers, and looking for other, lymphoma or CLL. So it is likely that it is related to the, and requires monitoring in the same fashion, but on its own, it's not a cancerous condition. It's a kind of pre-malignant, if you like. But in combination with your CLL, it'll be monitored, and it is linked to the disease.
We've got a...
Hello, Doctor.
Hi.
I've had multiple sclerosis for 25 years, and I was injecting interferons for that, and I was diagnosed with CLL 4 years ago. Could you please highlight any research that's been done on the significance of the side effects of that and its relationship to CLL, please?
So I think kind of...
Can you just explain the background?
Yeah, so sorry. So the background there is a question about interferon use over a number of years and the development of CLL at a later date, and if there's research in that field. And so I guess very broadly speaking, we know that patients that have long-term immunosuppression have a higher risk of other cancers, other malignancies. So a higher incidence. With regards to kind of specific research into it, I'm sure there are a lot of teams that are doing work on that, and I don't believe so locally that I know of, although Andy might be able to correct me. I think it's always difficult, isn't it? Treatments for any long-term conditions, we worry about those long-term impacts, and it would be very hard to know for each individual patient, was it the treatment or was this naturally going to happen in your case anyway, and without digging down and looking at, I guess, at a more cellular level, knowing whether or not that had a significant impact. But I would hope the treatment that you'd had for all that time, it's always considered and thought that, that is what you need at that time and in your best interests. Yeah, I'm sorry if that was not
I understand exactly what you're saying, because it is this not knowing, and there is a great deal of speculation on that, and I don't want to take any more time because I know that that's very specialised, but it is in relation to the high possibility now. My prognosis is that I'm not going to have chemotherapy, because I've actually been on chemotherapy because of the interferons that I injected for 12 years. So I'm very suspicious, shall we say, and I'm very reluctant to go because of the negative side effects that I no longer take. Thank you.
I'm querying or wanting information follow-up on, I think it was stage A, you said that for 80% of those patients, they would be alive in 10 years. And was that data collected in 2008?
So I expect it's a lot better.
Is there any update on that? Because I know many patients who have survived longer than that. And that's actually quite scary as well, that, if you say 80%, it's the half, is the cup half full or half empty? Mm. Do you see yourself in that 80%, or do you think, I'm going to die?
Mm. Yeah, no, so I'm sorry, I hope I haven't. So, yeah, so
Stella, could you just comment generally, because of the Zoom people, just
yes.
on the query there, and perhaps add a qualification to the fact that was 2008 data?
Yeah, so it was just regarding the 80% survival at 10 years, and that being old or historical data. So the prognosis has dramatically improved with our targeted therapies, and we have excellent, really excellent treatment options available now for our patients, and the prognosis is much improved.
Hi. Sorry for the, just about the COVID antiviral aspect. Lillian, who had CLL, contacted that while we were on holiday. She went to the GP, to ask for the antiviral, and the form that's given to the GPs wasn't fit for purpose. They said, well, you haven't had, or do you want to say?
Yeah, the doctor telephoned me and said, I understand that you obviously need the antivirals, but I don't think you fit the criteria because the questions I've got to answer on this form don't really apply to you. And there were various questions like, have I had chemotherapy? Have I had any other treatments? It went on and on and on. So in the end, I just said to the doctor, just write on it that I've had CLL for 14 years and I'm immune compromised, and send it off. And I did get the antivirals 2 days later.
But it wasn't fit for purpose.
No.
Yeah.
It was
So-
asking the wrong question.
Yeah. So my understanding was that actually it wasn't within the kind of primary care itself even, it was actually out with them, and that there was, so it was kind of government.
Well, apparently it was, but I only got COVID in March, and by then I think all the places that were sending out the stuff, I'd got a pack, but I didn't have anywhere to send
the positive test.
Yeah, so I didn't send a test off, but obviously I needed the virals quickly because you can't mess about, can you?
Yeah.
So it didn't work, so I just went straight to the GP, and our GPs are fantastic anyway. So
Yeah.
And it did work, but it just seems to be a blip in the system really that needs sorting out.
Yeah. I suspect it sounds like maybe the issue lies with having the tests available, because I think once you've done a test and registered it on the website,
That's right, yeah.
Hopefully it's smoother, a smoother process.
I just didn't have that available at the time, so
Yeah.
it's strange. Because obviously you'd have to send off for a test. That might take 2 or 3 days, and you need the antivirals within 5
As soon as,
days.
yeah.
So, yeah.
I'll have
I
to
know
think, I'm
Jane
not
was very
aware of
helpful
where we
because
can...
I spoke to Jane about it, and she was very helpful, and that helped sort it out as well, because we kind of put a bit of pressure on the GP, and it worked.
We mentioned before you came here today that you, if it was possible, we encourage you to take a lateral flow test.
Yeah, I did.
And certainly lateral flow tests are still available free of charge to people that are immunocompromised. So you can send off for them. We've had a link in a recent newsletter. I'm looking at John to make sure I'm saying the right thing. We've had a link in a recent newsletter that was telling you how to do that, but you can certainly still get free lateral flow tests. And I think you can still get them for carers of people who are immunocompromised, but I'm not sure about that. But certainly you have got that opportunity. Stella, could I just ask you one question about vaccinations? Yeah. So I read our leaflet that says that the Pneumovax vaccine can be repeated after 5 years. So I took the can to mean, oh, this sounds like a good thing. So I went off to my GP and said, can I have my repeat vaccine? And he, in fact, ticked the box, if you like. And I went in to see the nurse to get the vaccine. And the nurse, and indeed the nurse's supervisor, had very carefully looked at the Green Book. And in fact, it's something that people locally may choose to repeat after 5 years, but it's not something that's automatically repeated after 5 years. And indeed, people don't necessarily think you need to have it repeated after 5 years. So I just thought I'd add that ongoing learning. I see Andrew is nodding. That's just so reassuring, Andrew. Thank you. So don't panic and think you've got to go off and demand vaccinations, particularly the Pneumovax one being repeated. Your consultant or GP will be able to advise you on what's the best thing for you.
Yeah. Agree.
Got one more question here.
Yes, we've just got one final question we can have.
Continuing on the theme of vaccines, you mentioned the Shingrix, which is the safe shingles vaccine. Should partners of patients also be pushing to have the Shingrix? If you're living with an immunosuppressed person.
Yeah, so sorry, that's a question about should partners have the Shingrix vaccine. I think in the age group where it's offered, so the 70 to 79, that would be easy and useful to administer. I think out with that window, it would be very hard. It would be a slightly harder press to give. I think it would become a difficult balance of resource and to try and get that administered. Exception might be in a patient if you've had a really significant and nasty shingles episode. I think there'd be a stronger argument for vaccinating out with that window of partners.
One more?
Yes. So a final question.
Well, it's just a follow-on from that one of, do they need the Shingrix or could they have just the ordinary shingles?
They would need the non-live
The
vaccine.
same as the compromised?
Yes. Yeah.
Thank you.
So Stella, can I say thank you again for that? That was really, really helpful. And somebody said that when you come to conferences, you just pick up just a few tips that really help you. So some of us will have picked up a few tips. Others of us, if it's our first experience, will just be so eternally grateful to you for explaining the whole CLL world so clearly to us. So thank you very much indeed.